Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. And in this topic, we're going to talk about patterns of lung disease, approach to micronodules. Now, when we talk about micronodules in the lungs, they can be classified based on their size, their morphology, or their distribution. When they are less than 2 millimeters, we call them miliary nodules. When they are less than 6 millimeters, they are micronodules. Anything less than 3 centimeters is considered a nodule, a pulmonary nodule. Anything more than 3 centimeters is called a pulmonary mass. According to their morphology, they can either be solid, partly solid, or even have a ground glass attenuation. But what we are going to focus more on in this discussion is their distribution, how they're distributed. That's what's going to help us with our differentials. So they can either be distributed in a centrilobular pattern, in a perilymphatic distribution, or randomly distributed throughout the lungs. So starting off with the centrilobular nodules, they are basically opacities at the center of the secondary pulmonary lobule. You can see that most of our discussion is centering around this secondary pulmonary lobule. So when you have an opacity in the center of the secondary pulmonary lobule, we call it a centrilobular nodule. However, unless you are doing high resolution CT scan, you may not be able to see this exact shape of this secondary pulmonary lobule, and so you may not necessarily be able to see the opacification right in the center to call it a centrilobular nodule. So how are you able to tell on a CT scan or a chest CT? When you look at the nodules on a chest CT, there are certain areas that you can look at. So you can look at the subpleural areas. Centrilobular nodules will never extend to the subpleural region. Also, you can look at the fissures. When you look at your fissures, centrilobular nodules would also not extend to the fissures. They would always be within 5 to 10 millimeters from the pleural surface or from the fissural surfaces. So mainly infectious or inflammatory causes can cause centrilobular nodules. When you see them, think viral pneumonias or hypersensitivity pneumonitis. So this CT shows innumerable small lung nodules. You can see that the nodules spare the pleural surface and also some of the fissural and also the fissural surface as well. If you follow this fissure, there are really no nodules along it. You can see there's some kind of a gap between the most peripheral nodule and the pleural and fissural surfaces, indicating that they are centrilobular. The next we'll talk about is the perilymphatic nodules. Now we need to know the anatomic locations of the pulmonary lymphatics. That would give us an idea as to where perilymphatic nodules would be. So the anatomic locations of pulmonary lymphatics are the subpleural areas, the peribronchovascular areas, and the septal areas. So when you remember our diagram, our schematic for the secondary pulmonary lobule, we said that the lymphatics are in the periphery, right? So that makes sense to think that the septal parts, all the parts that would have these septi, the pleural surface, the fissural surface, and the interlobular surfaces will all have pulmonary lymphatics. Okay, so some of the main causes of perilymphatic nodules would be sarcoidosis, lymphangitic carcinomatosis, and pneumoconiosis. So looking at this image, it's a typical case of perilymphatic distribution of nodules in a patient with sarcoidosis. You can notice the nodules along the fissures. Follow this fissure. You can see some nodules along this fissure, some nodules along this fissure, indicating a perilymphatic distribution. Right, that's indicated by the red arrows here. Then there's also a peribronchovascular distribution of nodules around this area. This is a peribronchovascular ring, the bronchi and the vasculature around here, and just around here we are seeing some peribronchovascular nodules as well. Always look carefully for these nodules in the subpleural region along the fissures, because this finding is very specific for sarcoidosis. Typically in sarcoidosis, there is an upper lobe and perihilar predominance. And in this case, we see the majority of nodules located along the bronchovascular bundle. Still on sarcoidosis, there is what we call the galaxy sign, where you would have a confluence of nodules looking a little mass-like, but then around the nodules you still see some micronodules, making it look like a galaxy, as shown in this schematic here. So in this axial and coronal CT images, it demonstrates extensive upper lobe predominant confluent perilymphatic nodules, and the galaxy sign is most apparent on the axial image, where confluent nodules appear like confluence stars forming a galaxy. We have some here, we have some around here as well. Then for random nodules, as the name implies, they are distributed randomly. So you may see some of them along the pleural surface, you may see some of them appearing a little centrilobular, and it's just that it doesn't follow a particular pattern as either perilymphatic or centrilobular. It's just, as the name implies, random. And it usually occurs via hematogenous spread. So randomly distributed nodules are usually caused by hematogenous metastasis, disseminated mycobacteria, disseminated fungal infections. All these can cause the appearance of random distribution of micronodules. And in these schematics, the first one is a schematic of a secondary pulmonary lobule, and it demonstrates the nodules distributed randomly throughout the secondary pulmonary lobule. And the second one demonstrates the nodules scattered randomly. Some of the nodules are in close contact with the pleural surface, some of them are not. Now, this axial CT demonstrates multiple random nodules. Some of the nodules abut the pleural surface, like this tiny one here, like this one here and here, but some of them do not. And this was a case of metastatic colon cancer. Then we have what we call the miliary pattern of random nodules. And the miliary pattern describes innumerably tiny random nodules that are the size of millet seeds, less than 2 millimeters in size. And the major causes include miliary TB, miliary metastasis, pneumoconiosis, miliary sarcoidosis, healed varicella, pneumonia, among others. It's really a tall list of differentials and is very non-specific. So in this axial CT, it shows innumerable tiny nodules distributed randomly throughout both lungs in a miliary pattern. So this was a case of miliary tuberculosis. Then there is the tree in bud distribution of nodules, where you have endobronchial spread of disease. So we may have mucus, pus, or fluid, apart from affecting the alveoli, spreading into the bronchioles and the terminal bronchioles, giving it a budding tree branch appearance. And it's usually as a result of small airway infections or inflammation. Differentials include endobronchial spread of TB, viral pneumonia, aspiration pneumonia. Rarely lymphangitic carcinomatosis may also look like this. So this axial CT shows numerous small nodules shown by the yellow arrow, budding of linear branching structures in the right middle lobe here. This case was secondary to atypical mycobacteria, but you can see the classic tree in bud distribution that has been earlier described. So to summarize, when we look at the description of pulmonary nodules, especially their distribution, we are trying to tell whether they are perilymphatic, centrilobular, or random. If they are away from the pleural surface or the fissural surfaces or the septal surfaces, as shown in this diagram, you can call them centrilobular, and our differentials will include aspiration, inflammation like hypersensitivity pneumonitis, and some viral infections. If they are perilymphatic evidenced by they being subpleural just along the fissures and along the septi. We'll call them perilymphatic, and our differentials would include sarcoidosis, lymphangitic carcinomatosis. If they are a combination of perilymphatic and centrilobular but not specific to either one of them, we would say they are random, where we see some in the subpleural regions, some along the nodules, and some appearing central. Then our differentials would include metastasis, infection, among others. Thank you very much for your attention. Our next topic would be cavitary and cystic lung diseases. See you then.